I'm Gabrielle Rocque, and I'm a breast oncologist and associate professor of medicine at the University of Alabama at Birmingham.
And I'm Hennessy Williams. I'm an internal medicine physician at primary care with UAB.
We're excited to talk to you today about some common questions that come up in oncology and primary care. So, Dr. Williams, what do you think is the most common question that primary care doctors want to know about from oncologists?
So one situation that we see come up frequently on our screening mammogram results is a patient that is noted to have extremely dense breast tissue and that they might benefit from further imaging. How should we handle those patients?
That's a great question, and something that's been coming up and more often recently because of the new rules about discussing breast density in the mammography results. And so what we recommend in that case is that actually we move forward with a screening MRI because that can better identify potential breast cancers, particularly for those women who have dense breasts, and it's more difficult to tell in those women if there is a breast cancer in the background of that additional density.
Oh, sure. Okay.
Are there other questions that commonly come up related to screening?
Yes. Could you speak a little bit more of just how we should take into account a patient's family history when we guide them towards their recommended screening?
Absolutely. So family history is a really important part of how we think about screening for breast cancer. So in general, when you have a first-degree relative, so a parent or a sibling that has a breast cancer, particularly at a young age, we start screening 10 years before that previous person's diagnosis of breast cancer.
Okay.
In addition, we really want to take a good family history to understand who in the family has had different cancers, particularly breast and ovarian cancer. And in families where there are multiple different people with cancer, we often will think about genetic testing and potentially high-risk screening programs. So we will do genetic testing and additionally MRI for those women who have high risk, particularly greater than 20% lifetime risk of breast cancer. And we do have a screening program at the University of Alabama at Birmingham that is specifically geared towards those younger women who have family histories and are at higher risk of breast cancer.
Great. That's super helpful. What about any other special populations that we should be aware of where we should order imaging outside of typical screening?
Mm-hmm. So that's another really important point. So our typical screening starts at 40 years old, but we do know that sometimes breast cancer does happen in women who are younger than 40. So as a general rule of thumb, for a woman really of any age that has a new palpable breast mass, something that they notice on exam, we recommend moving forward with imaging no matter how old they are, just to be certain that we're not dealing with a breast cancer diagnosis. Another group that's really important to consider are those women who are pregnant or who have recently been pregnant. And so if you do have a person who is potentially breastfeeding, we do see mastitis and other types of problems. But if there is a mass, it's important to make sure that those women, particularly those women who are breastfeeding, are referred for imaging and mammogram.
Great. So we should get imaging regardless of if they're pregnant or breastfeeding.
Absolutely. So those patients definitely should be referred.
Perfect. Okay. So what about once we move on to our patients who are actively being treated for breast cancer? Are there any specific symptoms that we as primary care should be looking out for?
Yes, so oftentimes patients who are undergoing treatment will call their primary care physicians instead of their oncologist when something comes up. So some of the symptoms that we should be concerned about are usually things that would be considered a sign of infection. So if you have a patient who's recently had chemotherapy, usually it takes about 2 weeks for our common breast cancer chemotherapies to reach their nadir or their lowest point. So in that 1 to 2 week time period, if they have a fever or concerns for infection, we would be looking for neutropenic fever. So those are patients that really should be evaluated, and we usually think about screening labs, blood cultures, chest x-ray, and a urinalysis to look for potential sources of those fevers.
Okay, perfect. So many of our patients follow very closely with you all while they're undergoing treatment. Can you speak a little bit about how the transition should work when they complete treatment, transitioning from oncology to primary care, and what special things we should be doing for those patients?
So, as you mentioned, many patients are going to transition from their oncologist to their primary care physician. And that most often happens around 5 years for those patients that are not on treatment. For some patients that are still on hormone therapy, we will continue to follow them primarily in the oncology clinic for up to 10 years. But usually at that point, we are able to transition the patients. Now, ideally, those patients should come with a survivorship care plan that will help outline some of these recommendations. But some of the things that you would want to consider as a primary care physician are making sure that that patient has an annual mammogram and MRI, if appropriate or recommended, from the oncologist. Additionally, things to consider are bone density. So many of these patients will have had hormone therapies that will make them at risk for osteoporosis. So really ensuring that they're getting routine bone density checked. And then finally, as you are already doing in primary care, really encouraging a healthy weight and exercise and diet, as we know that that's important for their cardiovascular risk as well as their breast cancer.
Okay, great. That's helpful. What about maybe particular symptoms that we should be on the lookout for that might indicate perhaps a recurrence of the cancer?
That's an important point. So particularly as patients are getting further out from their breast cancer diagnosis, they are seeing primary care more often. And it's important to recognize that these patients can have recurrence. And so if a patient comes with a new symptom, for example, new back pain, that has been persistent and longer than you would expect for a usual ache or pain, or a cough that's lasted for longer than 4 to 6 weeks. Those are times at which we really want to think about imaging. So it's important in patients with a history of cancer to be mindful of new symptoms that are persistent and to go ahead and order those imaging either yourself or reach back out to the oncologist to see if perhaps that imaging would be indicated.
Sure. Okay, great. How about, could you speak a little bit about maybe some late effects of the chemotherapies that they might have received that we should be aware of?
Another important consideration is these late effects of chemotherapy. So in particular, some of the scary complications that we can have in breast cancer patients, particularly those who've received previous chemotherapy, one of them is heart failure. So thinking about if a patient comes in with new shortness of breath, with new leg swelling, or any other symptoms that might indicate a diagnosis of heart failure, being mindful that they are, particularly if they've had an anthracycline in the past, at greater risk of heart failure. Another issue that sometimes comes up, rare but serious complication, are secondary leukemias and myelodysplastic syndrome. And so really making sure that those patients, if they are feeling unwell, are getting a laboratory analysis, as complete blood count, to look for potential bone marrow problems that, might lead us to a diagnosis of acute leukemia. And I think another important point is to have these patients be getting their routine labs. So most patients, I assume following with primary care, will get an annual lab, and that's totally appropriate for that to be done through primary care rather than their oncologist. But we do like to see their liver function and kidney function and routine labs checked once a year.
Okay, great. Well, thank you so much, Dr. Rocque. That was so helpful in helping us as primary care doctors be able to take care of these patients.
And thank you for all the great care you take care of our patients and this opportunity to talk to you today.
Great. Thank you.
Thank you.